This program is brought to you by Emory University.
Okay, good morning. This is Gautam Kumar, and we are here at Emory University Hospital this morning for cardiovascular grand rounds. It gives me great pleasure to introduce my colleague and very good friend from the Atlanta VA Medical Center, Dr. Peter Wilson, who is going to be giving us a great update on lipids in 2022. Dr. Wilson is very well known in this field and has a CV that is much longer than, I could give a whole grand rounds on just his CV alone, but I will have Dr. Wilson talk about this. Dr. Wilson, please.
Great, thanks, Gautam. So this is an update. Some of this is going to be old hat, but a fair amount of it's going to be new, and I'll give you a feeling for where we're going. So first, we're going to start with familial hypercholesterolemia. And there's greater enthusiasm about identifying this because we now have aggressive therapies, as many of you know. And then I'll move into lipid measurements, what's new, what's old, what you should be doing, ASCVD prevention topics, and the focus is really going to be on LDL lowering and triglyceride, what's the latest, and then a take-home points. So if you fall asleep or if you're back watching this on a Zoom, wake up for the last 5 minutes and take home points. Okay. Xanthelasma, xanthomas and arcus corneae. Where do we stand on those? Remember, xantho is the Greek word or root for yellow. So these are yellow deposits with lipids, and the xanthelasma are right underneath the eye or at the corner of the eye. They can even be on the eyelid. Just have to look at the eyes. You have to think to do it. You have to think to have a person take off glasses if they have them. Xanthomas generally occur on extensor surfaces. I'm going to show you pictures of both of these. And then arcus corneae, we used to call it arcus senilis. But arcus corneae comes on, especially in people with darker pigmentation, starts in their 20s and 30s. It's generally fairly ripe in a darker skinned person by 40 or 50, even with relatively normal cholesterol. So it's helpful the younger the person is. You see an Indian person or you see an African-American person at age 55 with ARCUS, it doesn't necessarily help you very much to make the diagnosis of hypercholesterolemia. So here's some xanthelasma, both sides, both eyes, at the inner canthus, as you can see there. Xanthelasma. And this was noticed about 30 years ago, the most famous woman in the world. And everybody says, who was that? And that's the Mona Lisa. The Mona Lisa had xanthelasma. And it shows you that for even a couple of centuries when the painting was hanging in the Louvre, people weren't paying attention. Hey, she has these little yellow deposits around her eyes. Maybe she had something wrong. But so be observant and think to record it. Now, these are really severe Achilles tendon xanthomas. This is homozygous FH, HoFH, you'll see is the quick way to identify it. You're not going to see it this thick, but get used to feeling for Achilles tendons, especially in somebody you don't have the lipids yet. And you start to saying, okay, so you've got also a mother there and she happens to bring along her teenage child or even a very young child. You can reach and examine the Achilles tendon in that relative, and you can pick it up. You'll get very good. Normally, you're going to have a knife edge for a person with a normal cholesterol level, but with heterozygous FH, which is now about 101 to 150 people, you're going to get a rounding in even in a 20-year-old. Okay. Now, these are xanthomas on the extensor tendons of the hands, and get the patient to open and close the hand and get to know what they're not. They're not in the knuckle. They're not in the joint. They are not the contortions and the abnormalities that you see with syndesmophytes, other things for musicians. They're in the extensor tendons. So you'll see them there. You'll see them also on the elbows. May think you've got gout, but in fact, it could be a xanthoma, and then the Achilles, as I mentioned. Okay. Now here's ARCUS. This person has ARCUS bilaterally all the way around. You can see partial ARCUS, But things like ARCUS can go along with uncommon diseases. Hypercalcemia is perhaps the most common one that we see, but many things can cause ARCUS. Now, FH is an LDL receptor abnormality, and it's associated with these genes on the top. The most famous one, of course, is the LDL receptor itself, and Goldstein and Brown, the Nobel Prize work. But this has been recognized for, the last couple of 100 years. But now also apolipoprotein B and PCSK9 have been recognized. And then the PCSK9 led to a medication, as we'll get to as we go forward. I mentioned the clinical on the top, increased LDL cholesterol. The number of mutations keeps growing, at least 1,700, probably now 2,000. And then there are some groups that have more than the usual, but now the heterozygous FH is now not 1 in 500, which was in the medical textbooks about 10, 20 years ago. It's more common than that, more like 150 to 1 in 250 adults and in children, okay? And then the therapy, we start early, generally not treating in the first couple of years, but then moving quickly into virtually every medication. Some pediatricians are a little bit reluctant if the values are not extremely high to use statins, but you're going to start with the bile acid resins, cholesterol absorption inhibitors. And then when you get older, you're going to have a patient with PCSK9. And then for the person with the super high levels, an LDL, mind you, an LDL in the 400 or 500, you're going to go to apheresis sorts of treatment. So here at Emory, there is an apheresis program. Larry Sperling has historically in the past run this, and they're in the range of 10 people. Remember, you've got 1 per million, so that stands to reason. Here we are in northern Georgia, we're going to have 10 million people, and we're going to have 10 patients with homozygous FH. Now, this is a collaboration for a publication with Jan Sun, my colleague here at the School of Public Health, and this is in VA data, the Million Veterans Program, and this was our first 300,000. We now have about 800, 900,000 participants. But along the bottom here, the y-axis, are the SNPs, the single nucleotide polymorphisms. And then the max LDL is shown on the y-axis. And then an average is shown across there around 130. That's the typical American adult. But the 190 cut is where we start to identify and make the diagnosis of heterozygous FH. As you can see there, the most common SNP in the far left, look at those people. They mostly have normal LDL cholesterol. And remember, this is a marker that has 1,700 gene variants. So one of the questions comes up is, all right, I've got a high LDL. Should I do the genetic test? And most of the time, you're treating the LDL cholesterol level, you want to lower that, you're not treating the gene. Now, maybe the gene will add a little bit increased risk over and above, and maybe there are more than one gene this person may have, but in general, you don't need the genetic testing. It does come up a little bit for treatment and whether they're going to respond to the certain medications if they have null receptors, but in general, you're not going to need that testing. So stick with the LDL as the phenotype. This is another type of plot showing if you had those genes, any of approximately 20 of the SNPs that Dr. Sun studied in detail. And what diseases do they get? These are called PheWAS, phenome-wide association studies. You're going to get familiar with these types of things, or you could use this for blood pressure, for very high LDL cholesterol, as you can see here. And the point is, it's actually fairly simple. They all get vascular disease and they don't get other things. You don't see a signal there for getting skin cancer. You don't see it for kidney disease. It's virtually all vascular disease and lipids as a precursor. And the highest signals, as you can see in the upper left, very high statistical significance for lipid abnormalities. And they can get both high LDL and high LDL with triglyceride accompanying it. Now go back, we're gonna move more towards populations now. This is probably the most quoted data for high cholesterol and also for where you ought to be. So this is from the Mr. Fit screenees, several 100,000 screenees done in the 1980s by Jerry Stamler. As you can see there, as you move over for total cholesterol, it's a rather strong gradient. And then look at his bottom quantile. And the bottom quantile, and these are 20% quintiles, it's less than 182. So when he went to deciles, he got down to around 150. But we generally just don't have lots of population data much lower than 150. That's changing now with electronic health records. We're getting within the VA, but those are patients, not free living suburban participants in studies. We're getting LDLs in the 75 range, and you're starting to see a U shape. So in fact, it can go back up, and it may be frailty, it may be a variety of other conditions, and we haven't fully explained what's going on at very low LDL cholesterols. But it doesn't keep going down, down, down in terms of risk in the population setting. This is the same sort of thing. This is done by a study follow-up of Ansel Keys, which when I was in my early years, Ansel Keys was the leader for international studies. And as you can see, the same sort of trend and what I call sort of a hockey stick type of look as you come down and then you go relatively flat and you say, okay, I'm ready to move to Japan. Look at those low levels, quantiles, the very low LDL cholesterols or total cholesterols and low total mortality. That's also been observed in the United States, the same phenomenon, Asian individuals in the States. Moving beyond that, you can take lifetime risks. So what is one of us going to say to a patient if we see somebody today at, a 50-year-old patient and they have diabetes, they might not, they may have obesity, they have a variety of things. What is their lifetime risk? And so what you focus on here is sort of blending. This is at different levels of cholesterols. You can see three major groupings of cholesterol here. For the men over on the left, it's around that green grouping. It's generally around a 40%. And for women, it's less. It's around a 50%. So your lifetime risk at age 40 to 50, will I ever get heart disease before I die? It's around 40% in men and 30% in women. And a little bit higher, of course, if you have a higher cholesterol level at the time. Now, what to measure? I grew up in training and we just had total cholesterol. That's all we were measuring. We didn't even move to LDL cholesterol until really the 1970s in the lipid research clinics program, and then the drugs that started to lower LDL cholesterol. And for research purposes, that's the total cholesterol over there on the right. But now we have all these other opportunities. Should we be measuring any of these things? Everybody has agreed that we can measure HDL very reliably. So, all right, so I'm going to measure total and HDL. And do I need a VLDL or an indirect measure of it, an IDL, intermediate density, or LDL itself? So we calculate generally an LDL. And I show here on the bottom the classic Friedewald formula developed by Bill Friedewald when he was at NIH way back when. It was 1972. And now there are alternatives. There's Seth Martin's equation from Johns Hopkins. There's the Sampson equation from NIH. But you can still use the Friedewald, number one. Number two is the Friedewald falls apart and these others do a little bit better when you get very high triglycerides. But I always like to listen to what Scott Grundy says about something. And he says, if you've got a high triglyceride, let's say 500, 600, and you want to measure lipids, you've got a triglyceride problem. You got to get the triglyceride down. Do you really need your best effort to measure the LDL cholesterol in that situation? And the answer, he's probably right, is no. So just focus on getting the triglyceride down and then refining what you're doing. Don't get stuck up with just trying to measure the LDL cholesterol and being content to keep the person's triglyceride at that high level. All right, I'm just going to breeze by this. The average LDLs come down a little bit in the last 10 or 15 years. An average is 130. The 190 is where heterozygous FH starts. And all these others are general numbers. Women have higher HDL. Individuals who exercise have higher HDL. I'm going to give you a couple examples of these in qualitative tables. Okay. Now, this is a paper Rob Abbott and I wrote many years ago, and this is what we want to emphasize to patients. It's both your total cholesterol or your LDL and your HDL. And even with a very low total cholesterol, here in that front row, your total cholesterol is less than 192. The worse your HDL, in other words, a low HDL is not good. So HDL is the good one. You want to have a higher level, and the LDL is the opposite way. A high level has adverse health risk. Now, these are the LDL determinants. You're going to have patients who say, okay, what do I do? And I'll get to that in a little bit with medications. But this is the general rule of thumb, is to lower your saturated fat. Less dietary cholesterol. That is not as big as it used to be. People say, I need to avoid eggs. Probably not. You don't need to eat 5 eggs a day, but 1 or 2 eggs a day is probably not a major issue. In fact, nowadays, most Americans are not eating very many eggs, and you're getting your eggs in baked goods. You're getting it in pastries and breads and in other things. Higher intake of polyfat. Beware of the margarine types of trans fat, because that's not necessarily the best polyfat. And then another one for women as they go through menopause and the estrogens drop. The estrogens prior to menopause are favorable on the LDL effects. Now, different set of determinants for HDL, because we, of course, had a drug, but they didn't work for HDL. We had the cholesterol ester transfer protein drugs, the CETP drugs, and our colleague Creton Mavromatis was one of the investigators on that trial. They just didn't work. There was subgroup trial afterward for special gene groups. It also didn't really work. So we emphasize HDL and what are the things that patients should do. So first of all, you do better to be a woman. You do better to be in your early years and you have higher estrogen. You're thin, you're a non-smoker. A little bit of alcohol is actually pretty good for your HDL cholesterol, and you exercise. And they're genetic markers, as you might guess. And the other side, the flip side, is all those things on the left in the male and non-exercising, obesity, et cetera. What about the diet? Which diet should my patient follow? This is a summary of most diets. So where does, for instance, the American Heart Association come through? And it's right there in the middle, the adult treatment panel 3, and it's pretty much the same as that because of the sodium issues with the DASH diet developed and popularized by Frank Sachs and Larry Apple with their trials. ATP3, the zone, and the DASH are probably what Americans should be doing. And then you look at them and you look at what are the constituents and you sort of say, gee, they look all about the same, except for how much sodium there is. Now, what about the other diets? You're going to have patients that are going to come in and they're going to say, well, I want to follow the Atkins diet. Well, that's fine, but these are hard to sustain because of, for instance, very low carbohydrate with the Atkins diet. And then on the other side, with the Ornish diet, it's the flip. You have very high carbos, but in general, most diets work. The biggest issue in America nowadays is not so much the fat parts of the pot, it's the portion sizes and the caloric intake, because we have such issues with obesity. Okay, now, what am I going to tell my patient when I see him in the clinic and he's got a high LDL cholesterol and he was in a trial, or I'm ready to put him on a statin? What am I going to do to help convince him that I'm going to lower risk of heart disease? And this is the slide. This is the slide. At the bottom, and I put in a rectangle, 0.78. This is the 22% reduction in risk for cardiovascular events in the cholesterol treatment trial list meta-analysis. And this is more than 12 years old now. It really hasn't gotten any better. And it's mostly statins back then, but now we have other drugs on top of that. And we'll get to that in a few minutes. But the point is it's a 22% favorable effect. All right, now the next patient is a diabetic. Diabetics have higher risk. It's easy. I say the same thing. I'm not showing you that slide. It's again, 20 to 25% reduction in risk compared to the person who doesn't take a statin. And then he says, well, all right, but what about mortality? What about death? And that number is less convincing. So it's a 90% risk or a 10% reduction. But these are all highly statistically significant. I want to say we've probably spent in the range of $5 to $15 billion to make these statements. This was across mostly Western Europe and the United States for all these LDL lowering trials. Anything else I wanted to just sort of say, there's a major trial right now. What are the gaps? One of them is the prominent trial, which is being run out of Duke for statins in the elderly. So, and when does elderly start? Everybody agrees that you can have elderly would be above 75. It's no longer 65 in most of the definitions. So we undertook an analysis in the VA. This is Ariella Orkaby's analysis. And as you can see, the overall effect here, going down the bottom is, look, the null effect would be where the vertical arrow is. But in all the subgroups, for men, women, all races, all age groups over 75, diabetes, yes, no, they all benefited from statins in just an observational data analysis in the VA based on, as you can see, over 300,000 people at risk and many deaths. So the trial, the prominent trial, we'll see how that comes out. It's ongoing. It's probably going to be a few more years. Now, this is the slide you wanted. All right, if you're going to take notes, this might be the one to write down or put in your memory when you're talking to patients. Patient will say, well, I don't really want to take any medicines. I'm going to do great with diet. Most of the diets, you can't do a 3-month trial. You have to do a 1 to 2, 3-year trial. They're 5 to 15%. And the 15% are generally by groups that have had dietary instruction, number one. Number two, the statins, and I'm going to show you a following slide with the statin potency, and most of clinicians are aware of it. Statins are 30 to 50% drugs. And that's at usual doses in 80 to 90% of patients. It's different for patients who have trouble with statins, especially because of myalgias. And then going down to the different other drugs that you might add on or you might use for other reasons. Bile acid resins, cholestyramine, cholestyramine, the more you take, the more it lowers, but you have this gritty product or now you have tablets. There's not an awful lot of acceptance. Niacin, nicotinic acid, extended release forms, especially, but they're also slow niacin. All these have issues for how much you can go up. Liver toxicity at very high doses. These are 15% drugs. Ezetimibe is the second drug after statins nowadays, and it's a 20% on top of a statin. So it's, if your patient can't tolerate a statin at all, and we'll get to that, and is on ezetimibe alone, it's a 30%. But on top of a statin, it's generally a 20%. And then there's a new medicine on the block, a new oral medicine, bempedoic acid, works on acyl lyase and the citric acid cycle. It's a 20% on top of a statin. So, and bempedoic acid is now also being marketed as a combination with ezetimibe, targeting patients who can't take statins at all. And then there's injectable therapy. And I list the two names, AMAB, EMAB. It's a real mouthful. I simply call them the injectables, PCSK9s, every 2 weeks, 40 to 50%, also on top of a statin. So these are the people who are taking a statin, get down an LDL into the 70 milligrams per deciliter range, then add a PCSK9, they're going to get under 50 typically. All right. And then now there's another new one on top of this. inclisiran, and this is developed and in Britain, and it's now being marketed. And you'll see this, the ads for this now on the television, and there are no outcome trials, but this is also 35 to 80% on top of a statin, and it's dose dependent. And then finally, apheresis, as I mentioned before. Apheresis is highly efficient, but you've got to go every few weeks, and it's expensive, and it's really only for homozygotes. This is the one to remember for the high intensity, especially atorvastatin, rosuvastatin. Simvastatin was close to it at high dose, but remember simvastatin developed getting a black box because some of those patients at high dose in the SEARCH trial developed rhabdomyolysis, not just myositis, myalgias, but rhabdomyolysis. And there is a gene variant associated with that adverse effect. But for all the rest of these, and for most myalgias, we don't have genetic traceable effects. So you need to titrate dosing, and I'll mention that in a little bit. So what does statin prevent? It prevents cardiovascular disease, it reduces stroke, reduces MI. If you have acute coronary syndrome, it reduces your risk. You take a high dose statin. When you go home, you're going to reduce your risk of developing an MI or a severe event afterward. That was the Miracle trial done now about 20 years ago. It reduces PAD. It reduces amputation in the PAD patients. And Paul Ridker's even shown it reduces deep venous thrombosis, which is curious. We don't really understand that, I think. But it doesn't reduce certain things. If you have primarily muscle disease and your heart failure is secondary to muscle disease and not atherosclerotic coronary disease, it's not going to affect your heart failure risk. It doesn't work on calcified valves. That was shown in the SEAS study. Doesn't work on calcified arteries. So do not repeat a CAC score in your patient after 2 years after starting a statin, because in fact, it may get worse. You don't really need to do it. It's not going to be useful information. Patients already on dialysis, it doesn't work. If you have patient pre-dialysis, it does work. And a patient now is on pre-dialysis, it goes into dialysis. Should you stop your statin? We don't know. But the point is you should probably continue it. And then unanswered is what do we do in the elderly? Observational data would suggest treat, but we have a major trial underway sponsored by groups here in the United States. It's a PCORI study. All right, diabetes, that's one of the downsides. Perhaps one of the best analysis was done in the Jupiter post hoc study by Paul Ridker and his colleagues. So yes, there is a signal, statins increase risk, and as you can see here, 10% increase. But count out your metabolic syndrome variables, your obesity, high triglyceride, low HDL, et cetera. Each of those is a 5 to 10%er as well. So it should not be a deterrent for a patient to take a statin that they may push them into mild diabetes. Okay, now what about statins plus a second drug? And there have been a lot of trials, and that was reviewed as part of the lead up to the 2018 cholesterol guidelines. And one of them that got a lot of attention was the interleukin-1B blocker, and it was a positive study run by Dr. Ridker up in Boston. But then the follow-up was a methotrexate trial, and it was null. So we're still hanging out there. There no doubt will be more anti-inflammatory, maybe immunotherapy trials to test this hypothesis. But as of right now, it's still out there without an agent. The CANTOS trial, that medication was just never developed for use. This was a proof of principle question that was undertaken in a trial. What about the mechanisms of some of these newer studies and newer medications? So the first one I show here is in the blue in the middle. And most cardiology fellows, trainees, cardiologists themselves, physicians in general say statins work by reducing cholesterol production. Yeah, that's the secondary effect. Statins primarily work by increasing, upregulating your LDL receptors. So it's an LDL receptor issue. So if you get it, and remember most of your LDL receptors are in the liver, so it's a very favorable medicine. What about some of these others? And that's the coated pit, as you can see on the top of this cartoon. The newer ones, for instance, the antisense oligonucleotide mRNA inhibition with LPA lowering is yet another new drug, which is targeted towards LPA. That's another new medication which specifically may go for LPA. But up on the top right are the PCSK9 drugs, which are reducing the breakdown. Normally, you're going to get turnover of your LDL receptors, and this inhibits that. So think of your LDL receptors of having greater longevity. They last longer. They do a better job. And these injectables that go every 2 weeks are going to do, and then complementing that is the new one, that mechanism over on the far left, which is the inclisiran, is also very similar. Here's again, inclisiran. What are our guidelines for heterozygotes, okay? Estimate ASCVD risk. This is for the general population. Heterozygotes we treat. We don't need to estimate risk. But for the general population, we go ahead, use the pooled cohort equations. We talk about risk enhancing factors, and I'll show you that list. And then consider doing a coronary artery calcium, a CAC score, as a possibility. So I'm not going to go through this. This is mostly to remind you of these different risks. Less than 5%, it's all lifestyle. Then you have 5% to 20%. Generally, you have intermediate levels. And then for those greater than 20%, consider CAC scoring. And then serious LDL reduction is important. Now, this is the risk enhancing factors. I find this somewhat, oh my goodness, how am I supposed to remember all of those factors? But if you print it out and you have it on a little sheet, it's something that helps guide whether you're going to be more aggressive. For instance, I'm in the VA clinic, and I'll just go down quickly. Most of my patients who are, all right, so most veterans are heavy, so they got and they have hypertension, so they have that LDL that's high. They have metabolic syndrome. They may have an underlying disease. We have a fair number with HIV. They may also have elevated triglycerides. I don't generally measure C-reactive protein. I don't generally measure Lp(a). I'll come back to that in a second. And I don't normally do APO measurements or ankle-brachial index. So I have 2 or 3 of those things that help prompt me to be more aggressive. All right. Now, what about the CAC score? The CAC score, everybody uses a slightly different one. The US and Europeans consider, but the 100 plus is generally considered by the guidelines. I think we could probably get lots of debate about that. Really, what should the cutoff be? Another strategy that you have that is the 0. And that's been popularized by investigators in the MESA study, Roger Blumenthal and his junior colleagues, Mike Blaha and others, is that a 0 actually is maybe I don't need the stats, because the person might have a borderline, but now there's 0 calcification. So consider both ends of the spectrum to help guide your therapy. All right. Now, what about adverse effects for lipids? Myalgias are the most common by far, 5 to 15%. Myositis with high CKs are uncommon. People ask me often, Peter, how high will the CK be before you have to stop? And I live with it 3 to 5 times. So a normal CK in my labs is around 300. So once it gets 1,000 to 2,000, I'm measuring the CK every time I'm measuring lipids. And I warn patients about things that might put them at greater risk. Entering races, not getting adequate fluids, et cetera, when they're out in hot weather may increase their risk of rhabdomyolysis, which is the next one, which is uncommon and associated with acute kidney injury. Now, of course, some patients, as we know, you see it in the charts, and I've seen a handful of these over the years, get rhabdomyolysis. And first thing you do is you go to a second statin, a very low dose, and if you get a second rhabdomyolysis, you're pretty much done with statins, especially if you've used 2 different molecules, and you're going to move to an injectable therapy as needed for those patients. The other question that comes up is liver function abnormalities. Again, I play it by ear. So 3 times upper limit of normal. And most of the SGLOTs, SGPTs are in the 40 milligram unit range. So once I get over 100, I'm also measuring the LFTs every time. They get much higher and I stop. Somebody with a history of hepatitis, however, things like that, they are not contraindications to using statins. And I got a fair number of patients on those over the years. Okay. Adverse effects. Constipation's the big one for residents, but that's not used very much. Nicotinic acid, niacin, flushing. You can reduce that with aspirin. You should take it with food. You can get gout. You can get some liver toxicity. For those who remember, many years ago, there was the niacin 7-week cholesterol cure. High dose niacin led some of those patients got severe liver toxicity. Cholesterol absorption inhibitors, ezetimibe is the classic drug here. Generally, you can handle with a mild liver disease, but the new one, bempedoic acid, gout is the side effect to watch out for. And PCSK9, the injectables, as well as inclisiran, the other new injectable, which is with a greater duration between the injections, you get site reactions and flu-like illnesses, but generally not much discontinuation for either of the injectables. The big issues is cost and insurance. Lp(a), I got to mention this one. There's more enthusiasm about Lp(a) and when should it get measured? So it's an LDL molecule here in the center in the yellow with a protein squiggling around it, and then a special protein with these little kringles, the apolipoprotein A, which is attached to an LDL molecule. So it's a special risk factor. And as you can see there in the top, you should measure it, especially early onset. Ron Krause's editorial on this, advisory, 10 years old, still holds early onset ASCVD. For instance, an MI age 40, get an Lp(a), have it in the chart. You don't need to keep tracking it, but have it in the chart. Make sure you don't have an Lp(a) issue. Historically, they'll often have venous disease. It's fairly common here in the South. At higher levels for those who are from Africa or African-American, and it runs in families. It's the most heritable of all of the lipoproteins. And the reason that there's some enthusiasm about it, as you can see, statins, no effect. Fibrates, mild effect. Nicotinic acid, which we don't use so much now, a mild effect, mild to moderate. PCSK9 also in the range of nicotinic acid level. But now there's a new drug, Ijeoma Iziodenso, our colleague here, I believe, is recruiting for this for those who have very high Lp(a), is a antisense injection, and it's dose dependent. You can get up to 80% lowering. So some people, you have a person who, for instance, has an LDL, had an MI, age 45, you see him in clinic, and you say, gee, I should now get his Lpa. And his LDL was not above 190, it was 160, 170. And then you measure his Lp(a) and it comes back 70, not 10 or 15, 70, 80. Well, that person may become a candidate for this newer medicine, which is now only under clinical trials at this point. All right, a little bit about triglycerides, and then we'll finish with our wrap up and our take home points. So what are these? These are extensor surfaces, looks like a rash. On the knees, you can get it on the buttocks, you can get it on the back. They may burn, they may itch. These are from high triglycerides. You may think it was prickly heat, something like that if it's on the back, the person lying down. I'm going to show you some more. Here's some more pictures. This is the same thing on an A. This is in D, the bottom one, are very severe hypertriglyceridemias. You may get, as you can see in the upper right, lipemia retinalis, if you look in at the retina. And then you may also get a yellow line in the creases of the palm with hypertriglyceridemia. You can also get that with super high LDL cholesterol. You can get that with some rare lipid abnormalities. And if you draw plasma and you just set it in a test tube rack and let it settle out, you get lipemic serum. One of the questions I often ask endocrinology and cardiology fellows. I said, if you look at that slide there on the, the B, who's got lipemic serum? I bet there's lipemic serum in every hospital, major hospital, at every day. And they say, really, it's that common? I said, yeah, can you tell me what the diagnosis is for those people? And they scratched their head. And I said, every medical student used to know this when I was in training, because when patients with certain diagnoses came in, we drew a blood and we kept a tube on the ward. We can't do this anymore with HIPAA. We taped it to the wall. And what was the diagnosis for that patient? And they say, I don't know, Dr. Wilson, we don't do that anymore. And I said, it was diabetic ketoacidosis. Everybody with DKA pretty much has lipemic serum. So don't measure the lipids at that point. The other group that really has lipemic serum is the third trimester of pregnancy. Generally, unless you really think you need to, don't measure lipids, because a healthy woman who's going to have a healthy delivery will often have lipemic serum as well. It can be a marker for preeclampsia, but in general, the persons who have the very high TGs like this is over 500, 600, perhaps over 1,000. Once you get over 1,000 for your triglycerides, you don't have really too much confidence to know exactly what your lab is doing. So did they dilute it to figure out exactly how high it is above 1,000? You don't know. We used to dilute them when I was running the Framingham labs, and at NIH when I was there, they used to dilute them. The highest I've seen is 17,000. So, and those were dilutions, but it doesn't really matter. Once it's over 1,000, you're going to treat 1,000, 10,000, and 15,000, all the same. You're going to get the triglycerides down. And we'll talk about that, okay? So we're generally here dealing with outpatients. Historically, the common drug that we went for has been fibrates. And the oldest drug is gemfibrozole. There have been other fibrates outside the United States, but gemfibrozole in the States, and then later followed by fenofibrate, another fibrate in the States. Fenofibrate combines with less risk for rhabdomyolysis in patients with a statin. Pheno does better than gemfibrozole. So in fact, most of the time we're using fenofibrate, and they're both off patent. So these are, you go with the cost effectiveness for this. And they're not expensive drugs, but you can see you can get GI side effects and cholecystitis. Niacin extended release is a little not as potent, but easier to take. The immediate release is the one that really can cause the flushing, but you take aspirin ahead of time. Omega-3s. All right, what's the latest on omega-3s? A couple of slides I'm going to show you about that. Omega-3s, if you're going to lower triglycerides for a patient, and this is your patient now above 500 or 600, over 1,000, you're going to probably have them on omega-3 plus fibrate. That's the modern 1-2 combination. You're talking about 4 grams a day. You're talking about you're going to write a prescription. The person's not going to go pick up 1 gram a day at Target or Walmart or something. That is not prescription level omega-3. And you don't really have great confidence exactly what's in those products. And then you see over the right, it says atrial fibrillation. Yep, and we don't know how that caused. That's been seen. Almost everybody who has investigated this in population studies and recently in the VASC-EPA trial, which I'll show you some more data about, it was seen there. So there is a minor signal, it's just a few percent of increased risk for AFib, and not known how it works. Triglycerides in general are not lowered very much with statins, and it's the higher doses. So if you take 10 of atorvastatin, don't expect to see any. You have 80 of atorvastatin, you're going to get some, but you might not get that much, and it's not fully predictable. And ezetimibe also not that much lowering of triglycerides. So the cornerstones are fibrates, generally fenofibrate, secondary gemfibrozole, and omega-3s. And this is the construction from the guidelines. There's not a big emphasis in the cholesterol lipid guidelines in 2018, 2019. but this is what Scott Grundy and his colleagues summarized. In general, as you can see there on the top, the group with the TGs over 1,000, first of all, screen them for other diseases. ChemProfile is going to do this rather quickly. And then you've got these intermediate groups to the left up at the top there with the 500 to 1,000. And your goal is, the goal of the cholesterol triglyceride guideline group is to get it under 500. Not to get it less than 150, but to get it under 500, okay? And remember when that trial was coming out, we had a VASC-EPA trial that was coming out and called Reduce It. The paper was written in New England Journal, came out American Heart Association, presented by Deepak Bhatt from Boston, all right? So what about, this is sort of the summary of the effects here. Triglyceride change, 4 grams a day omega-3, you're going to get a 20% lowering, but you have minimal risk for bleeding and minimal issues for increasing LDL. And often if you need to lower LDL, you also have a statin on board. Now look at the center panel there, the meta-analysis. Decreased CHD, 11%, stroke less, MACE low, except for the Reduce It trial, 25% reduction in MACE. So this is, and remember what happened this is VASC-EPA, EPA. It's an EPA only, icosapentaenoic enoic acid. It's a real mouthful. And the icosa starts out with EICO, pentaenoic. So it's EPA. 25% difference. Think of it as a difference compared to the placebo or the comparator. Do you remember what the comparator was? I do. It was mineral oil. It was not corn oil. So there was concern even when that paper came out. Well, maybe that comparator is not the best comparator. All right. So is this, we had one study that sort of sticks out, 3-point MACE, and you wouldn't have predicted that from the meta-analysis right above there, right? Okay, well, we got an answer, we think. Those of us who are readers, I have nothing to do with this study, but this is Paul Ridker's post hoc analysis of Reduce It, taking time 0 to 12-month lipid measurements and biomarker measurements in the mineral oil comparator versus the icosapentaenoic, the EPA only. And then you say, okay, well, just start at the bottom. LDL cholesterol went up 11% in the mineral oil group. Well, that doesn't sound good. And then everything went up that he investigated, all of his battery of inflammatory and biomarkers, oxidized LDL, CRP, interleukins, LP-Lily, everything went up at highly statistically significant. And it looks like he measured a lot of things, and he measured them in tremendous numbers of participants. So I think we have an answer. We had a positive trial because the comparator arm did worse. Their LDLs went up, and in fact, they had a higher risk, and you might have gotten an effect from the EPA, but it really became significant because the comparator was not a good comparator. Okay. Take home points. All right. Got to go beyond diet for the most part. I think diet is always part of the conversation with all of our patients. And for those who are quite mild lipid issues who won't take a medicine, it should become part of their lifestyle. And this is especially important for somebody's family. If you have heterozygous FH, and we have a fair number of patients, all of us have those in our clinics, the family should move to a healthy diet as well. And that's hard with all the advertising for the unhealthy foods we have in the States. Statins are the cornerstone of therapy, and the guidelines reflect this. I'm mostly using the potent statins, and I think that's true for those of us in clinics with high-risk patients. So atorvastatin and rosuvastatin. Now, titrating patients. This is something we should all do. So I'll just mention a vignette to give an example. So I have Mr. Jones, let's say, and he's taken atorvastatin. He had angina, and he gets put on atorvastatin 40, and he gets myalgias. He sees his physician, and he switches him out, and he puts him on another potent statin. So he goes from atorva, and he goes to Rasuva, and he's on 20 of Rasuva. And then 4 months later, he gets myalgias again. Now, what do you do? So that's a typical patient I have in my clinic. So what I do is I say, well, for each of these, you only lasted 3 or 4 months. If you had lasted longer on one, I would say, let's go back to the one you lasted longer. Okay. So, all right, we'll go back to that one. And I want you to take a low dose. And I'll say, well, I have high risk, Dr. Wilson. I have coronary disease. I want you to take a low dose. You're sensitive to statins. So a low dose typically is something like 10. Let's take 10 milligrams a day of atorvastatin. And what I want you to do is, if you have any problems, you get muscle aches, you know, your thigh cramping, your upper arms cramping, those would be classic on a Monday. Well, maybe you did a lot of work in the yard over the weekend. Maybe you did moving stuff. Maybe you were exercising, something a little unusual. So take a statin holiday. What's a statin holiday, Dr. Wilson? Statin holiday is you keep taking all your other medicines, but you don't take your statin. And then you go back and you start taking your statin again at either the same dose or a lower dose. Oh, lower dose. So how much is a lower dose? I've got 10 milligrams. Well, a lower dose would be something less than, I talk about this, 10 milligrams times 7 is 70 milligrams per week. So let's start talking about how much you get per week. Okay, how about 10 milligrams every other day? That might be one of the ways. Or if you have a 10 milligram tablet, you go to 5 milligrams every day. There are different ways to do this. It does help for patients who are at low dose. What we want you on is the maximally tolerated statin. For a patient who's on a very low dose, they can't do it with 20 milligram tablets, just to let you know. I actually specify in the prescription, dispense 10 milligram tablets, because if you can't take a 20 milligram tablet and cut it in anything smaller than a half, because I might get a person back down to taking 5 milligrams 3 times a week. But think about it. These people are sensitive and they over-respond. And I'll get them to do it. And some of them, Dr. Wilson, I don't believe it. Here we are. I'm only taking 5 milligrams a day and I'm getting 30% lower. I say, yeah. And now we could try to go up a little bit, but the next step is if you have coronary disease, is we may, and we're not getting to an LDL goal that we've chosen and was recommended by the guidelines. Next step would be to add ezetimibe for that patient. So, and that's just what I gave you a vignette of what I do with patients. And I'm microdosing and low dosing virtually every patient who comes on referral as a statin. And I call it partial intolerance. I don't like the word intolerant because I can usually find a statin that they can tolerate. That's take home point 1. Take home point 2 is for TGs, get them consistently less than 1,000, ideally less than 500. And if you started the medicine and they get less than 500 milligrams per deciliter and they're on a fibrate and omega-3, you might ease up on one. The omega-3 may be more cumbersome to take because there are many pills. So you may try to decrease the omega-3, but you're going to continue. You want to keep them under 500 milligrams per deciliter. How aggressive we can get because of the most recent post hoc analyses of the REDUCE-IT trial, we don't really know. We just really don't know. And finally, Lp(a), think of it for your patients, especially those with early coronary disease. And most biomarkers, I didn't get into that too much, are not needed. You can do your job with total cholesterol, triglycerides, HDL, and a calculated LDL cholesterol, and really do well for almost all of your patients without adding lots of extra biomarkers. So thanks very much. Questions?
Peter, it's
Dr.
Jeff Bear. I had a question.
Sure.
Thanks for the presentation. That was great. You know, I'm interested in the Vascepa or icosapent ethyl, and you know, I'm just curious what your thoughts are trying to figure this mineral oil issue out. There was the Jealous trial that showed benefit of EPA. I mean, that was the only other EPA trial that was done that I'm aware of. And they both showed benefit, which made me feel better that maybe Vascepa is actually doing something. And so I'm just kind of curious what your thoughts are about that.
So Jeffrey Bear's question was about what do we really do with omega-3s? And so there was a 25% difference in risk in the Vascepa trial. And then if you were to put together the omega-3 meta-analysis, you would probably expect a 10% difference. And that's where I think it's settled down. It probably is a 10%er difference when you add omega-3, but it's not 25%er, and it's not specific to that drug. The other is the Jealous trial that he mentioned is a Japanese trial, also used icosapent, it's a mouthful, used EPA only. That I don't think I think we'll find the effect with the DHA and the EPA, but that's not seriously been tested. And the Japanese trial was also in the era of lower dose statins and lower dose EPA. So nowadays, most of the recommendations are to use 4 grams. And of course, we're now titrated most people up who are at fairly high risk to take a potent statin at close to the top prescription dosing for that statin. And so I don't think, what we don't have an answer for, what Jeffrey's really going after is our patient with 200, TG 200 to 500, how aggressive should we be? And we should probably be giving them something, but we do not necessarily have to drive it extremely low. And whether we'll get another trial, the answer is probably no. So I didn't show a slide on this, but Dr. Ridker ran the most recent statin plus fibrate trial. It was a statin plus pemafibrate trial, and it was null. So the answer is pretty much fibrate plus added to a statin. We're not getting very strong at all about this. And we're left a little bit hanging with omega-3 issues, 4 grams of omega-3, but for what purpose? Other than to get them out of risk for pancreatitis.
Very good. When you see a patient for the first time, or for example, when we have one of our house officers sees a patient for the first time, like has a stent or has a catheter, has minor disease, you want to start him on a statin. What should we tell our house officers as far as starting a statin on a dose? You're going to write them a prescription, send them out. Do you start them at 80 milligrams a day, or do you start them at 10 milligrams a day, or what? What should we tell our house officers about that?
Yeah, you know, I've always wrestled with that myself. And the guidelines are especially targeted towards outpatient initiation of therapy. And I think where Steve Clement's going with his question is, all right, so you had a patient who just got a stent and you send him home on 80 of Atorva, and you didn't have that extra conversation. If you have trouble, don't just toss it off to the side and then come back and see me 3 months, 3 months from now, and you're on nothing. You need to be on something. And so the way to do it probably is to have that conversation is, we need you on your maximally tolerated dose. So I'm not sending these patients home, but Steve, you are, is I would have the maximally tolerated conversation then, or have a sheet. I think we could probably do this with a handout sheet to the patient at discharge. All right, if you can't tolerate the dose and you write it in, it's 40 or 80 for that patient, okay? And if you can't tolerate, I want you to stop for 5 days, and I want you the first time to start back at the same dose. If you have it again, I want you to start back at a lower dose. And then you write in the blank there how you want that patient to do it. I would cut it in half. And then the other point is, if you're now starting to have an issue with toleration or tolerability for this patient, is down at the bottom. We don't want to see you at 6 months. We want to see you a little sooner, at least for a phone call and a dose adjustment, because those patients really need to be on medicines. And we know it works. The Miracles study was, and every one that's been done in ACS patients has been positive, but we just can't have people drop off entirely. And then because then you find out later than you wanted, and you'll try dose number, medication number 2. So you'll just move to the other statin if they're new to statins. But if they've ever had issues, I think we should be having that conversation earlier in the game than what becomes a lipid clinic referral. Yeah.
Absolutely. I think that you have to have that conversation with them. I'm not sure we're having that conversation with them as we should, but those alternatives start out a lower dose, and if you see them back in 3 or 4 weeks, you can ask them how they're doing then, but you definitely need to have that conversation.
Well, the guidance is always to take one of the top doses, 40 or 80 or 20 or 40 for the 2 potent statins. I'm with you on that. The same, but I'm always seeing them on referral, and I think we could probably avoid some of these referrals. And I think perhaps this would be something we could operationalize clinically with handouts, so.
Peter, this is Spencer King. What do you do with primary prevention for people who have LDLs that are not really elevated, say 100? You make any recommendation for drug therapy in these people? Just the average person, totally primary prevention.
All right, so LDL of 100. And so my guess is you have to decide where is the patient. Is the patient in a general medical clinic, or is the patient already now in a office of a cardiologist or a preventive cardiologist, and they're concerned? So the rule of thumb generally would be you don't have to treat, and you would simply provide lifestyle. Now, some people would get quite aggressive. So the average LDL now is around 130, and it keeps creeping down a little bit. This person's most likely, if they have conventional risk factors, is to get metabolic syndrome and then maybe slip into heart disease a different way. The modern way to get heart disease is probably through metabolic syndrome and hypertension that's not as well controlled, and develop heart failure, not necessarily to develop coronary artery disease. So you're probably not wrong at all to hand out a low dose statin, but then there's no guideline that's going to say that's the case. In the same way that the Jerry Stamlers of the world would say for blood pressure, well, you don't necessarily need a blood pressure medicine if you have virtually no salt in your diet and you have normal blood pressure. But we've gotten more and more towards a diuretic or a diuretic plus a second agent. And then now you're getting very close to, you can see where I'm going, Spencer, is a very low dose statin and a low dose blood pressure medicine, including a thiazide diuretic and maybe a second agent. And you have some form of a polypill, and which Salim Yusuf has been touting all around the world. And it's easier to just have a polypill for many patients and not have to track too many things. So we don't have an answer. And in the US, I think those of us would probably, in preventive cardiology and cardiology as well, are aggressive. If you talk to lipidologists and endocrinologists and preventive cardiologists, they are on the uptake of these medicines themselves more aggressively than what is in the guidelines. But the point is also the very low dose statin has almost no side effects. It's a very benign drug. Perhaps the most famous cardiologist has, I heard recently, is even buying in more into the injectables. And that cardiologist bought in very early into potent statins. and that's cardiologist is Eugene Brownwell. He still is very much in favor of aggressive LDL lowering.
The preceding program is copyrighted by Emory University.